Hey everybody, David here. And this is a little bit of a sidetrack, I guess is what Nicole and Mark would call it over on Nevermind the Music. Over the course of the season, one of our listeners on the Discord has been writing in, and turns out that they are an ICU nurse. And so Sarah has become our chief medical correspondent for the show and writing in on a regular basis, letting us know what certain things are or how to understand certain medical procedures and whatnot. And I invited her to come onto the podcast for a little bit, and she graciously accepted. And so I got to spend a good 45, 50 minutes with Sarah, learning about her work and what she does. The conversation veers a little bit into politics and sort of capitalism and corporate management of healthcare. So we tried to steer it away from that a little bit, but we couldn't help but bump into those issues. So just sort of letting you know about that. Otherwise, great time talking with Sarah, really interesting and great insights, and just as I think a great indicator of the depth of community that we have that has clustered around the Lorehounds, and the kind of cool people that like to listen to the shows and to then sort of share with the community their insights in their own personal lives. So we really appreciate Sarah spending some time with us. She herself is a bit of a nerd as well, and so we're now her nerd herd. So I love that. We talk a little bit that at the end of the show. But it's just great to be able to find people who are into the same kinds of stuff as we all are, all in different walks of life and different professions and stuff like that. And we get to come together over a show like the Pitt. So everyone on the Discord, give a shout out to Sarah on the channel and thank her for her time and her wisdom. And otherwise, here is my conversation with Sarah. And we'll see you later this week for the next episode of the Pitt. So, Ogilvy. What are we supposed to make of Ogilvy? Because John and I have our beef.
Oh, I know. He's like a med student still, and a lot of times they kind of have that like need to show off.
Okay. Especially coming in on their first day, they want to prove themselves.
Yeah. And although I think he's a little more cocky than most of them that I've ever met, a lot of them are very scared. Like on their first day, they like walk up with their like hands under their chins and they're like, "I'm here for my first day." But the ones that are more like him, I have met some that are like him, and they learn.
Right.
It takes some time. They learn. Right. They learn that they can't, what they can and can't say, how they can and can't act. I give him a little bit of leeway because he's a med student on his first day.
Right.
But he's punchable sometimes.
Are you at a teaching hospital as well?
I am. I've pretty much always worked at a teaching hospital.
And those are is that like a special designation, or is that just a special arrangement with a school or something? Or
so most of the teaching hospitals are like the big university hospitals,
right?
That have medical schools attached to them. So. I started as a baby nurse at a teaching hospital.
Like Emma?
Yeah, at a big university hospital. And I still work at a big university hospital. So,
got it. And is that, how long have you been doing that now?
So, I'm going to date myself here.
Yeah.
I have been a nurse since 2001.
Okay.
So 25 years.
Right. And did you know that this is what you wanted to do when you were studying?
When I graduated from high school, I initially went into like a biochem major as a pre-med. And then after my first semester and a half of college, I was like, I don't want to do this for 10 years of my life before I actually get into the workforce. So I had friends that were nurses, like friends of my parents that were nurses. And I spoke with a few of them. And they're like, if you want to be in it now, this is do this. Time. Yeah. Right. So I went to nursing school instead. And
did it feel like your calling when you?
I did. I think I brought it up in like one of the Discords that I was like ER the show ER was the reason I went into healthcare. And so now the Pitt is like
exactly.
Yeah, so like I watched ER as a teen, and I was like,
I watched too much Wild Kingdom when I was a kid, so
and I was like, I want to do that.
Yeah.
And yeah, as soon as I was actually in it, I was like, yeah, this is what I was supposed to do. So
got it. It felt normal. It felt like putting on the glove. And
yeah.
Like, yeah, this is it. Did you know your specialty was going to be in emergency medicine, or did
so
that
I
take
actually worked in the ICU, in trauma ICU.
Okay. Oof. Whoa.
Yeah.
That's even more intense, right? But they're stable by that point, right? And so
not
you're really
necessarily.
okay.
I initially wanted to work in an emergency department, and then I spent like one shadow shift in an emergency department. I was like, I do not want to work in an emergency department. It is.
Look, my cat. She's here. I told you she'd come. We were before, just to let everybody know, before Mike's, we were getting settled, and we were joking about our cats making interruptions. So
yeah, and I was. It's the emergency department is like pure chaos. And so I actually started out, I was supposed to actually work in transplant. And
oh, wow.
The first day I showed up on the unit for my first orientation shift, the charge nurse ran out crying, and people were like, it was horrible. It was a shit show.
Right.
And,
you can swear on this podcast. It's okay.
And they were like, we're going to send you across the hall to orient because we're having some issues over here. And I was like, oh, this is not a good first impression.
Yeah.
And across the hall was trauma surgery. So I oriented with them.
That's like Garcia.
Yeah.
Yeah.
Yep. So by the time I was like halfway through my orientation, I was like, can I just stay here and not go back across the hall? And they're like, absolutely. So that was how I ended up in trauma. And so I did 4 years on a floor, a regular med-surg floor, which was trauma.
Okay.
And then I went to the ICU, and I've been an ICU nurse since then. So trauma ICU is controlled chaos is what we like to call it. So
got it.
And our trauma surgeons would always like to get their patients out of the emergency department as soon as possible. So they would be calling us
street level medicine.
Exactly. They'd be calling us and they'd be like, how fast can we get this patient up there?
Right.
So if they didn't have to go directly to the operating room, they would come directly up to us within an hour, usually. So they were still pretty unstable. And then we had more controlled chaos in the ICU. But we saw all the same things they see in the ED. We saw tons of gunshot wounds and car accidents and stabbings.
Right. Given the size of PTMC, is Dr. Hashimi correct in that they really need to have two attendings on duty at all times? Yeah,
they probably need more than two, actually.
At least on a busy holiday weekend, you would want more than two.
Even like the little community hospitals usually have at least two. So the big university hospitals, I don't think we ever had less than 4 attendings on.
Wow. Oh, wow. So this is a real anomaly then.
Yeah. This is the
Robbie's
one thing.
Egos trip?
I think this is so they don't have to introduce you to so many people on the show.
Exactly.
I think it's purely for dramatic purposes, but.
Got it. And would there be a lot of jockeying and hierarchy among the attendings on a shift like that?
I feel like most of the emergency room attendings get along pretty well together. They work together all the time. Mm-hmm. I mean, I'm sure there are some personality issues. There always are with doctors, but
right.
I did see some between like the trauma surgeons when the trauma surgeons would come down and the emergency department attendings. Like sometimes they'd get in a little tiffs about things.
Right. And the way that they're depicting the flow of patients, that kind of pace and that sort of chaos. Does that feel like, I don't know how you could watch the show if that's like your reality. And then you come like, I know most people, they would want to watch something that is far from their professional so that they could disassociate and dissipate all of that energy and intensity.
I mean, I definitely watch other things to do that.
Yeah, that's good. Okay, good.
But the Pitt, I don't know. I feel like it's like...
What's the magic then? What's the magic about the Pitt?
It has the same feel as ER had to me when I was, a teenager watching it. Like it has a lot of the same qualities, I feel like. And I know Wiley is probably part of that.
Right.
But the flow is definitely very much realistic. Like it's
Mm-hmm.
emergency departments are chaotic always. But I feel like sometimes when I'm watching it, it actually gives me an outlet to like let go of some of my feelings that I've pushed down at work. Because
Interesting.
when you're at work in that position, like you're around family members and other patients, like you can't let all that out or you would be in a corner somewhere rocking. And
we saw Javadi processing that. We don't say oops in front of patients, right?
Like Robbie's panic attack in season 1, like if we let that stuff bubble to the surface at work, that would be how all of us would be. So I kind of feel a little bit like watching this, like I can get some of those feelings out when I'm sitting on my couch, safe at home.
Right. In a controlled environment. And like McKay said, she was like, I don't know if I remember how to turn on my emotions. Maybe she should sit down and watch the Pitt after a shift. Because Mohan, the way the advice he gave to Mohan was like force field walls.
Yeah.
Like it takes a lot of psychological strength to be able to set those boundaries while you're there. I can imagine.
Absolutely.
I can't imagine. That's the thing. Without violating any sort of patient confidentiality, is like what's something funny that like is at the top of your mind of something that happened?
I mean, we had one patient who she was a prostitute, a sex worker.
Okay.
And she had been shot outside like a drug house.
Oh my God.
And she was there for a very long time. She was very ill when she first came in. We got her through all of it. But she was a little confused, but like a lot of patients end up confused once they've been in the ICU for a prolonged period of time. But when she was starting to come around and get better, and she was restrained because she kept like trying to pull out her lines and stuff.
Right. Is that a common thing?
Yes, that's very common.
Right.
It's because she was offering everyone sexual favors to untie her. When you'd walk everyone, male, female, didn't matter.
That's pretty funny.
Yeah.
But I thought that was really interesting with McKay taking Ogilvy across the park the other episode, was this idea of like meeting patients where they are. I mean, obviously you're dealing with them as they're coming in, but the people are really dealing with some of the worst days of their lives.
Yeah. Mm-hmm.
And it's got to be pretty intense.
Definitely. It's not easy. And I worked in a hospital. I've moved since then. I still work in a university hospital, but the hospital I worked at was like the big hospital for the region that I lived in. And I every day was worried that someone I would know would come in and show up.
Oh, yeah. Yeah.
And so that was like one other level of stress. But
right. Because you never know who's coming in through the wheel. Yeah, coming in on the on the gurneys. Yeah. So on the shifts, do you work? What it seems like, John and I have been talking about this on the show, the amazing outcomes that we can achieve, but the malappropriation of, how healthcare is distributed. And a lot of it just seems like it's structural in terms of shifts and overlap and staff and all of these kinds of stuff. Is that the case? Do you guys, what's the average shift length do you work?
So most nurses work 12-hour shifts.
12 hours.
Yeah. So I have pretty much
some breaks.
Technically. Okay. I think you guys were actually talking about it on the podcast this week about like someone like not taking their break and setting the culture that like, and nurses are like that all the time. Like, we usually work 7 to 7, which ends up being 7 to 7:30 because they factor in the 30-minute lunch that you get.
Oh my God, that's so bean country.
Yes, it is. It's very much. So, and I've worked nights since the second year that I was a nurse. So I work 7 p.m. to 7:30 a.m.
Okay.
Technically, you're supposed to get 2 15s and a 30-minute lunch. You're lucky if you get your 30-minute lunch. So most of the time, that's at your desk while you're doing charting or something, which is technically not a non-interrupted break, but nurses do it all the time. And I think that part of nurses have been victimized a little bit by corporate culture. I think hospitals prey on our empathy and it's a mostly female dominated profession.
Yeah.
And they prey on our empathy and they're like, well, we're all a family. We're all like, it's for the patients. And so this week when
if I was a family, if we were a family, you couldn't fire me.
Right, exactly.
Come on. This analogy does not work.
So like traditionally, like nurses have put up with a lot and gotten kind of kicked down the road where like we don't get paid for that 30 minutes, even though we're technically working during that 30 minutes because we're charting. Because if we don't chart during that 30 minutes, we don't get out on time and we don't get home to our beds or our families or whatever.
And get the rest you need to be able to come back to do it again.
Correct. The nice thing is most nurses only work 36 hours a week. So we work 3 12-hour shifts a week. But everybody's like, oh, you only work 3 days a week. That must be so nice. But you need 2 days to recover from working those 3 days. So.
Right. Just literally being on your feet that amount of time.
Yeah.
And whenever you're sitting down, I'm sure it's not to rest as much as it is like using a terminal or something.
Correct.
Like
yeah. If you're sitting, you're charting. There's a call light going off. There's a vent alarm going off. There's an IV pump going off. Like you don't sit for long before you're getting up back down.
Right. And then trying to eat and a bathroom break. Like we saw that in season 1 where I think Robbie was trying to get to the bathroom like most of the episode.
Yeah. If you have a very sick patient, you might not get a bathroom break or you have to find someone who's going to come in and sit with your patient while you go to the bathroom because sometimes you're like, I've had patients that are so sick that you can't leave the bedside, really. It's just too precarious.
Are you a fan of Devil Wears Prada, the movie?
I thought the first one.
Yeah, like, the first one.
Originally, Isn't there
there's a very funny line. Emily Blunt she has to go to the bathroom and she makes, what's her name, man the phones. And it's a funny thing, but not at all related to healthcare. just
I was like, I saw the first one when it came out. It was so long ago. I'm bad with movie quotes.
That's fine. Well, that's tough too. And then the number of nurses that are available, let alone whether we have enough pay to go around for all of them.
Yeah.
What's the overlap between shifts?
So like I work nights, so I work 7 p.m. to 7:30 a.m. So day shift comes in at 7 a.m. So there's that 30 minutes.
30 minutes to hand over.
To hand off, yeah.
Do you end up staying late a lot of times?
It depends on the day. Luckily,
it's not uncommon for you.
No, it's not uncommon. And luckily in the ICU, you usually only have 1 or 2 patients. So it's easier to get out. The poor med-surg nurses have 4, 5, 6 patients to hand off. And that takes a lot longer. So I think it's more common for them to get out late than it is for the ICU nurses. But like if you have a patient like circling the drain at change of shift, then sometimes you're there till 9 o'clock.
Right. And and John and I were talking about this on the last pod. Sometimes that's just the way it goes. And that's fine. And an adult and as a professional and somebody who's committed to your profession, you go the extra mile every once in a while, but that's the exception, not the rule.
Yeah.
Right. That's in a free and fair society. That's what the idea is.
That is. I do have to say, like when they put Joy in this last week, where she was like, "I'm not getting paid to do this. I'm leaving."
Yeah.
There has been a little bit, just the start of a cultural shift towards like more quality of life, more balance of work life, because the generation that's coming into the workforce now is much more keen on work-life balance than like my generation.
Right. Well, and we had that great conversation with what's her name, the nurse, the clerk nurse who came in, who was out having her smoke break and talking to Javati.
What is her
I'm blanking. I have to look at the
Melanie.
show guide.
I know. It was like.
Have you looked at the show guide?
Yes, I have.
Okay. Where is it? I'm scrolling. It's here somewhere. Monica.
Yeah,
Peters.
I was like, it starts with an M. My notes starts with an M.
Yeah, and the that sort of weird flex that she does. Like, well, I had to strict. I was like, wow, okay. And Javati's like, whoa,
yeah.
I don't know what to process. I don't know how to deal with this.
Yeah, but it is kind of good, like that this coming up generation that's entering the workforce is definitely, I think, going to help shift the culture.
Okay.
To more work-life balance than it has traditionally been.
And this is going to be interesting because you're going to have that culture clash coming in with administration, with the way that hospitals are administered, and not just a individual hospital, but hospitals are often parts of much bigger conglomerates of hospitals. And so it's not even necessarily your administrator in your facility that you might be dealing with. There's a corporate structure well above, way up in the clouds somewhere where somebody else is setting these policies.
Yeah, and I think that's why recently we've seen a lot more nurses striking that are the ones that are unionized, which is not most nurses, I don't think. But the ones that are unionized, you've started to see them striking for safe patient-nurse ratios and healthcare workplace violence protocols and fair pay.
My local hospital, they just voted for a strike. So we'll see if it actually happens, and then see what we do. And that's it's a hard one. It's not like UPS drivers going on strike or something like that. Oh no, I'm not going to get my pet food delivery or my weird rubber thing that I bought from wherever. This is literally life and death for people.
Yeah, and hospitals have they have strike insurance, and then they pay for a bunch of travelers to come in and work the strike, and they pay them exorbitant amounts of money. And instead of just giving you a fair contract,
exactly.
And the patient safety is horrible during those events. If your hospital's striking, I don't recommend you going there unless you absolutely have to.
We had a bus driver strike happening because our local bus company got taken over by a one of these private equity firms, and then it was a family company that operated for years and years and years, and then they sold. Then nobody in their family wanted to take the business anymore, so they sold to this private equity firm, who obviously came in and she started changing the HR policies and stuff. And they brought in these drivers on the first day of school. People were waiting 2-3 hours. Where's my kid? Because the poor, the workers that they brought in, they don't know this place. They don't. Right. A lot of them, the English isn't their first language, and so they're trying to read instruction sheets or understand what's going on. It's really horrible. So when we mix profit, I'm sorry, this is getting way off to the left here.
We're getting deep.
But, but mixing profit in terms of health outcomes and human well-being and these kinds of things, it gets really messy.
Yeah, absolutely.
So. How is this, do you have any idea of, are you going to stay as an ICU nurse? Or are you looking to do a little bit more, or are you pretty much in your groove and you're just cruising down the road?
So I actually just recently transitioned into the PACU, which is post-anesthesia care, which is a recovery room.
Okay.
Not very long ago. So I was an ICU nurse up until this last year.
Okay.
So recovery room, much less stressful. You still have to be critical care certified because some of those patients come out sick, but so much less stressful. And I was I tell everybody I retired to the PACU because it's so much less stress than the ICU was.
Right.
But after, I was 21 years of ICU.
Are the hospitals providing enough professional mental health support?
I mean, they try to
they talk a good game.
I think it's a lot of corporate places where they're
we keep steering over into this ditch.
I know. Well,
sorry, everybody.
This is healthcare these days.
Right, exactly.
Unfortunately. Yeah. There's the corporate speak of we have EAP, and we have a meditation room, and we have yoga. And,
meditation room is where you go sleep between shifts.
You can download the Calm app on your phone for free.
Oh my gosh.
So that's the kind of stuff they give us.
Right. That's crazy. Let's talk about the emergency department a little bit more. We got this season a couple of fun extra characters, given that the electronic systems went down. We got the clinical pharmacologist. The internet freaked out Dr. Megan Nort. Everybody on the internet, all the pharmacists were like, "We're seen!" They were like super excited, and yeah, and I talked about this on the pod last time, like this whole idea with the beers list and with that the couple with the medication interactions, like how important. Talk a little bit about the importance of clinical pharmacology in your workplace.
I think they're so important. And when I was in the ICU, we actually had a clinical pharmacist that rounded with us every day. So when the team rounded, it was the attending and the residents and the nurses, and the clinical pharmacist would round with us every day. And so that pharmacists would go through their med list and say, hey, we should change these antibiotics because their blood cultures came back and these are not appropriate, or they've been on these for 12 days and they don't need them anymore. This med can interact with that med. And it's so important, especially in our big like trauma patients that also have like brain injuries, because we got a lot of brain injuries. So really important to get their med lists correct so that you were minimizing the amount of confusion that meds were causing compared to what their head injury was already causing.
Right.
Or just being in the ICU sedated for so long. And also antibiotic stewardship is a big thing. This is how you're getting resistant.
MRSA.
Yeah. MRSA.
Yeah. MRSA has touched my life directly.
Yeah.
Not me personally, but in my family.
Yeah.
Affected my
MRSA,
family.
VRE.
What's VRE?
It's vancomycin.
We should act. We're throwing some acronyms around.
I know. It's vancomycin resistant enterococcus. It's another bug. It's resistant to an antibiotic. Necrotizing fasciitis is often caused by antibiotic resistant.
No way, really?
Yeah.
I thought it was just some sort of weird exotic bug that lived in a pond or something that you
it's usually no. No, necrotizing fasciitis is usually common bacteria, but it gets into like open wounds, and so you have to like be very.
So did Robbie do the right thing when he did the steel
Absolutely,
test?
Like that. Necrotizing fasciitis can kill you so fast, like it. Right. So when he did that and was like, get somebody down here that knows what they're doing right now, because you need to go to the operating room. I've seen necrotizing fasciitis go from like the size of a pencil eraser to entirely across someone's chest and up their neck in a matter of hours.
Wow.
So that's
terrifying. But
like, this is why pharmacists are so important, because they will pick up on that. Like, this is the wrong antibiotic for this bacteria, or they've been on this too long. They've not been on this long enough. Helps prevent those drug resistant bugs from getting worse.
From developing. Yeah. Right. Because we were just liberally applying sorry, what my brain just
antibiotics.
Antibiotics. Like antibacterial? No, antibiotics. We were just kind of like antibiotics for you and for you and for you.
Mm-hmm.
And so we're sort of a victim of our own problems there.
Yeah.
What about the Dr. Nick, or I don't know if he's a doctor, the radiologist.
Radiologists are usually doctors, yes.
Yeah, okay. But that little mobile radiology x-ray cart, that looked really cool. Is that something that you guys have?
Yeah, so that was just like a portable x-ray machine.
Okay.
So we do portable chest x-rays all the time with them. You can do other portable x-rays with them, but most commonly we do chest x-rays with them. And then you can pull the x-ray up on the screen. And so,
you can, and if you can read that result and you have less time of, transporting the patient somewhere and back, that just seems like a really great medical device.
Yeah, I would say most of the time when we're using it for chest x-rays, we're looking for like a pneumonia, fluid overload, or the position of like an endotracheal tube, which is, helping them breathe.
Right.
Or we put in NG tubes, which are tubes that go through your nose into your stomach to feed you.
Right.
So we're usually
squirming right now.
We're usually looking for one of those things, and the doctors that are on the unit with us can usually look at them on the screen and be like, "Okay, this is fine. This is where it's supposed to be, or this is pneumonia, or this is fluid overload." But in the case where like their whole system was down and you couldn't pull anything up on the computer, it was pretty smart of them to get a radiologist up there out of the basement to read them on the fly for them.
Are they often in the basement because that's like the power and weight? Like you don't have to move it up to the upper floors? Because some of those machines are pretty big. CTs and MRIs.
Yeah, those are usually, pretty much every hospital I've ever worked in, they've been on like the ground floor.
Right. Makes it easier. Now, I know cyber attack is a big thing just across industry in general, and hospitals and are particularly at risk. The way that they handled it in the show, how do you feel? Did it break your verisimilitude, or did it seem okay? Like, to me, it seemed a little bit dopey, like computers going off now, boop, and like you can't even like shut the network down, but leave the computers on. I don't know. It just seemed to me like a little bit.
Yeah, I feel like it was very extreme, honestly.
Okay. Would it cause you to come to a halt like that? Like, I mean, it would probably,
if it all got shut down. Yeah, it would. We do like planned downtimes where they update things in the system.
Right.
But we always have like a read-only version of the chart available to us so that at least we can see like what meds they're getting or what they're
the
here
last
for.
Updated version of it. Yeah.
Correct. We can't do anything in it, but we can at least see it. So if we had to go full on paper with no charts at all, that would be hard.
Because they rolled out those whiteboards like they were waiting. They didn't, some environmental staff or, some other hospital administrator, like, what are these doing here? Get them down to the basement or whatever.
Yeah.
Like that, they had those like that.
Yeah,
that
they did.
Seems to me like pretty far-fetched.
Yeah, I think they'd probably have to go search for them in some closet somewhere.
Exactly. That would seem
we have to have like a tote of paperwork that we pull out and like pull out all the papers.
Now, and fax machine, did you have a tote full of toner cartridges?
We actually still use a fax machine.
Yeah, I know. Actually, I know that's true, right? Because moving medical records around, they're like, well, you can fax them to us. I'm like, I don't have a fax.
I know. Yeah, no, we when we request blood from the blood bank, we have to fax the request down to the blood bank. And I'm like, why are we using a fax machine still?
It's a HIPAA thing, isn't it?
I think part of it, but like the blood releases in their system and prints down in their lab. So I don't know why that we have to fax it to them too.
But I go to my pharmacy, my local whatever pharmacy, and they know everything. They're like, let me look. Well, the state said this and the insurance said that and the doctor said this. And I'm like, wow. And it's just, it's pretty wild the way that medical records work these days. Yeah,
we have, like things upload to your like My Chart or whatever system you're in like very quickly. And like it does occasionally cause problems with like family members because like they'll be like, how come their labs weren't drawn? And you're like, their labs were drawn. What are you talking about? And they're like, well, they're not in their My Chart yet. And I'm like, I can't help that, but we did draw them.
It just hasn't cycled. You haven't waited long enough for them to come through. Oh man. Okay. Well, so what's your hot takes on the season so far?
I really like it. I think that it's been interesting. It's definitely like less dramatic than last season because there's not like the big, mass casualty event that was at the end of last season. At least I hope they don't. And we didn't
know, what the season, if they were going to get greenlit or whatever. So I think they went big a little bit. I think they went bigger to catch everybody.
So from that point of view, it's like a little calm. It's more of like an average day in the emergency department rather than a mass casualty day.
That was John's point in the last pod too. Like if that's what it is, that's what it is. This is good.
But I think they bring up so many good points to like make people think about like all the things that we have already talked about, like the corporatization of healthcare and staffing and workplace violence. And so I think that it's doing a really good job of like putting those things out there for you to see and talk about without like shoving them down your throat. Like, because I think there are some shows that kind of shove their point of view down your throat.
Right.
But I think they're doing a good job of that.
It's kind of weird. It's kind of meta because if PTMC is a teaching hospital, this is a teaching television show.
Yeah.
The show is literally teaching us about the American healthcare part and one aspect of the American healthcare industry and healthcare space. Do you have any? What's your hot take on Dr. Al-Hashimi? Okay, so there you go. You want to work for Robbie or you want to work for Dr. Al-Hashimi?
Ooh, that's a tough one
though, right?
That is a tough one. Like Dr. Robbie definitely has his issues, and it seems like he could be hard to get along with at times, but I think he's a really good mentor also at other times. Right. Whereas Dr. Hashimi, I have a hard time reading her. Mm-hmm. And I think that might be harder to work for.
Right. Yeah. Because she's not, the way that she dropped it on Dr. McKay, she was like, oh, I don't know if motherhood has made me more empathetic or more judgmental. I'm like, whoa, that was a real hard brace. Like, because she was basically telling McKay, stop gossiping about that woman. Stop thinking those thoughts about it. Like, stop it. Yeah. But she did it in such a weird way that it was like, how do I read you?
And also, like, do we know she had kids? Like,
we do. She mentioned it once before. When
did she? I don't remember that. So I was like,
it was. She said it. I think it was to Robbie, and she was defending AI. She said, if my AI app will let me get home to my kid faster at the end of the night or whatever.
Because I was like, I don't remember her saying she had kids before, so I was dealing with that, and where I was like, okay, did I miss that?
And Dr. Santos, do we call her doctor? When do we call somebody doctor or not?
Yeah, Santos would be called a doctor. So first year residency, which is also an intern, they get called doctor.
Right. It's like
technically a doctor.
Right. If you are a lieutenant commander, but you take charge of a ship, by custom, they call you captain. Mm-hmm. Because you're the person in charge. You're the person in charge of that. You don't have the rank, but you have the responsibility.
Yeah. So like the hospital ranking, like you have med students. Usually you don't get med students till like their third or fourth year usually. Okay. They have a short coat, usually if they're wearing a coat. And then you get interns or first year residents. They are doctors. They graduate in May, and in July, poof, they become doctors. Right. And then you have R2s, which are second year residents, R3s, third year residents. Right. R4s are usually chief residents. So like each service will have a chief resident, which is kind of like the person that looks down on everybody underneath them. Okay. And the kind of a senior class mentor person. Yeah. And then the attending is above everybody. Okay.
So then Mohan and Langdon and McKay, Ellis, even Mel, I guess, they're residents. They're senior residents and residents.
I think that they're like R3s.
Okay. So they're not that much farther ahead than Whitaker and Santos.
Yeah.
A year or two.
Yeah.
Okay. That's a lot of experience in a short period of time.
Yeah, doctors get a lot of experience in a short period of
time. What do you make of Dr. Santos and Dr. Whitaker? Do you enjoy them as characters?
I love them together. Like, I think they're such great foils for each other.
Totally.
Like Whitaker's just kind of like a little naive and very country bumpkin-y. And then Santos is kind of hard and sharp, and I think a little more worldly.
Right.
So I think that together
she's gooey inside, though, too.
Yeah, I think she hides it very well, but inside there, she's gooey. But I think them together, they're like great foils for each other.
And Dr. King?
I love Mel, too.
Yeah.
I just think she's sweet.
Yeah, she's really great. We talked, I think McKay is coming out to be my MVP for the senior residents, for that resident level. Joy Kwan is obviously just bringing a lot of joy to it. What do we do with Langdon? Because this whole dilemma, he actually stole controlled substance.
I know.
But he's a great doctor, and now that he's not being a jerk, he's kind of a cool guy.
Yeah. Langdon is tough because, unfortunately, this is not an uncommon situation, especially in emergency medicine. And I think in anesthesia a lot, there's a lot of drug problems.
Wow. Okay.
And I think that it's not uncommon for them to brush things under the rug with doctors. Okay. I think if it was a nurse that they caught stealing drugs,
boom,
she would have been gone immediately. Gone.
Right.
But I have
not even end of shift. Now gone.
Yeah. She would be walked out with security.
Right.
Out of the hospital. And reported to the board of nursing to lose her license, and reported to the police probably to be arrested.
Right.
But unfortunately, I've seen this in real life where a physician was having some substance abuse issues. And
right.
I didn't personally see this person steal drugs, but I can't imagine they weren't taking drugs from the hospital.
Mm-hmm.
And I think that part of it was brushed straight under the rug.
Right.
And they went to rehab and they came back and they were,
So the rehab journey is not uncommon. Like it's not something that it's not surprising. Okay. That's interesting. Did you watch The Rehearsal?
I did not.
Okay. Season 2 is really interesting because it's all about airline pilots. It's a weird show. I don't know what your tastes are in television.
I've heard about that show and it was on my watch list and then it got lost somewhere.
But you talk about like professional, how professions are encapsulated and dealt with. I don't think there's any drug issues in there, but it's about airline pilots, right? It's like people entrusted with the safety and welfare of so many other people. Like how do we approach them, and how do we as society and allow them to be themselves, but at the same time when you're on duty your hand 300, 400, 500 people are in your hands in one given go. So I think it's an interesting conundrum. Do you have any opinions about the nursing staff? Do you have
So I think this is one very unrealistic thing about the show is you would have many more nurses in that emergency department.
Got it. I think there's plenty around. Like if you watch the background action, there's nurses everywhere. We're only
but you would see them doing much more of the things than they are doing. So all the IV placements, all the blood draws, all the vital signs, all the med giving, all of that is done by nurses. Like there's no way, like that lady that had the retinal artery occlusion that they gave TPA to, that she would not have been monitored by a doctor. She would have been monitored by a nurse only. They would have done hourly. Well, there's a protocol when you give TPA. It's every 15 minutes for 6 hours. So you do 15-minute neuro checks for.
How many timers do you have running on your phone at any given time? Do you talk to your watch?
Could be many.
Yeah. That's crazy. I mean, like Great British Bake Off or anything like that. They got nothing on you guys.
Yeah, I know.
You're keeping track of everything. If you got to hang out with a nurse or two after shift, would you hang out with Princess or Perla or Jesse or Mateo? Like who's your people?
I mean, I love Dana.
Baby Jane Doe. Not enough people have called in on it. I'm upset at our listeners. I wanted more Baby Jane Doe reports.
I think she reminds me a little bit of myself. So I was.
Oh, okay. Do you keep 4 milligrams of Versed in your pocket?
I do not.
Is that a syringe in your pocket? Or are you not happy to see me?
But I don't know. I think Mateo's pretty cool. I'd probably hang out with Mateo. I like Jesse. I don't know. Princess and Perla are a little too gossipy for me. I try to stay away from the gossip a little bit.
Got it.
I like them, but I think they're a little too gossipy.
Donnie's pretty cool. I mean,
Donnie.
He's a pretty cool guy. Yeah. He's an LPN, right? Now that's another level.
Donnie's
of
a nurse practitioner.
Sorry. I'm mixing my acronyms around. He's a nurse practitioner. What's the difference between it, just for folks at home? Like, what's the difference between a nurse practitioner and a nurse?
So there are LPNs, there are RNs, there are nurse practitioners. So an LPN is a licensed practical nurse. They're actually,
and that's I called Donnie an LPN. That was the wrong thing to call him. Sorry, everybody.
Fading out LPNs a little bit.
Interesting. Okay.
Mostly we'll find LPNs in nursing homes.
Oh, okay. Right.
LPNs have like vocational training. They technically can't assess a patient. They can't give IV push medications. They can't hang the first dose of any IV medication. There are certain things. Would an
LPN and a paramedic be at what level to each other? Because a paramedic can administer certain drugs.
Yeah, a paramedic is closer to like on level with an RN.
RN, okay.
I would say. So then an RN is more schooling, more clinical time. We can assess a patient. We can give IV push medications. We can hang IV first doses of IV medications. We can access central lines.
Right.
You're going to find us in hospitals, mostly RNs. Nurse practitioners have an extra. Some states are a master's degree. A lot of states are now moving towards doctorate degrees. So a lot of NPs are now doctorates. So they have extra schooling where they are allowed to practice medicine in a specified lane, basically. So they can do acute care, they can do geriatrics, they can do psych, things like that. But,
and where you don't have to have a doctor, that frees up the doctor.
Right. So nurse practitioners can write prescriptions. They can do full assessments, H&Ps and stuff on patients. So
got it.
You'll find them in the hospital. You'll find them in clinics, urgent cares. They work a lot of urgent cares. Nurse practitioners don't need a doctor to co-sign their orders. Whereas you also have physician assistants as well. Right.
Yeah. I forgot about that.
So physician's assistants are usually a master's program, I believe, at this point. They may be heading towards a doctorate for them too. But and a PA and an NP are pretty close to the same level.
Gotcha.
PAs can also write scripts and do assessments and stuff like that. But PAs have to work under a physician, whereas an NP doesn't have to technically work under a physician in most states. There are some states where that differs, but...
Got it. Right. Yeah. And then we have state to state things as well.
Yeah.
Right? Yeah. There's that gets all kind of crazy. What's your kind of go-to TV watching when you come home besides the Pitt? Like what would we find you watching on
well, I'm a big Hot D, Game of Thrones.
Nice. Okay.
How I found you guys. Rings
I
of
was going to
Power.
ask you, how did you stumble across us?
I actually think it was the Lorehounds, like the actual like Tolkien stuff.
The Tolkien stuff. Yeah.
Yeah. Because
Rings of Power.
I'm one of the people that I was even before Rings of Power. Like I'm one of the people that have read the Silmarillion.
Right.
So I think it was like that book stuff that mostly how I found you guys. And then
the message to John is to hurry up and finish with the Silmarillion. Right?
Yeah.
Because he sort of drifted away. Okay.
Gives me something to come back to.
But we have Marilyn kicking around.
Yeah.
So,
I know. I love listening to Marilyn. She's so interesting.
Yeah.
So I watched those shows. I'm also a big Outlander fan. So last season of Outlander, I'm so sad. And then
did you do Paradise this year?
I did not.
Okay, that's a wacky show. I know are you more the fantasy stuff?
I like the fantasy stuff. I like the period drama. So like the Gilded Age is another one that I watched.
Alicia and Lisa just put out some stuff on that. They did a Wuthering Heights one. They did a Gilded Age one a while back. Yeah.
So I like a lot of those things.
Cool.
I did an Interview with a Vampire.
Okay, yeah. John and Alicia are excited for that. That's coming back this year.
Yeah, the first couple of seasons were really good. So I'm excited for the next season of that.
Cool.
I watch a little bit of everything. I try to stay away from reality TV. I'm not a big reality TV person. Yeah.
Cool. Are you looking forward to anything in particular this year coming back? Do you have anything that's exciting?
I don't. I have so many things on a list, and then I forget to watch them.
Right.
And then
House of the Dragon. We're assuming sometime in June, so we're not sure yet.
I watched. I loved Night of the Seven Kingdoms.
Yeah,
I thought that was so fun.
Yeah.
So that got me back into all right, looking forward to Hot D coming back.
Right. Are you a Star Wars person at all?
I do like Star Wars. I haven't watched a lot of the new stuff.
Okay, I'm really excited for the new Maul Shadow Lord animated. It starts in about a week or so. We're going to do some coverage on that.
Nice.
Yeah,
and I watched Aliens Earth.
Oh, yeah.
That was good.
Yeah.
I'm like, what else have I watched?
Yeah, it's hard to keep track of everything.
I know.
That's why we have the show tracker.
I know.
Check out the show tracker.
It's part of the... I was like, what are they talking about this? All right, I'll start watching that.
Yeah, nice. Perfect. Awesome. Cool. Well, this is fun. I really appreciate you have been super diligent about sending us in emails and answering our questions. So I can't thank you enough for taking the time to write in and give, you're a really good writer. All of your emails are very clear. It's very complex stuff and you lay it out really well. And I feel like it's just been valuable to have you there. So on behalf of all the listeners, thanks for taking the time to connect with us.
I've always liked teaching. Like when I precept do nurses, like my whole thing is like, tell me why we do this. Like if you tell me why, then you know, like,
right. So
like I've always really liked teaching people. So when you guys started asking medical questions and I was like, oh, nobody's actually answering them. I guess I can answer them.
No, that's good too, because if you think the why, then all the technical stuff can come after that. But you need to, like, if you understand the why about something, then you have a greater understanding as a whole.
Yeah. Yeah. I've never been like, all right, just do this task. No, tell me why we're doing this for this.
Right. And and widen your viewpoint as a practitioner, right? As a professional. Yeah. Cool. Any other pearls of wisdom you want to drop on us, or
I don't know.
Be nice to Ogilvy. Have compassion for Ogilvy.
I mean, cut him a little bit of slack just because he's like.
I know. I can hear John in my head right now. He's like, no.
I know. John hates Ogilvy. I can see where he's coming from. I really can. And it is hard to remember that it's his first day.
Yes.
As a medical student. So if you can remember that, it's a little easier to cut him a little slack, but he has a lot of learning to do. I have to.
Absolutely. Yeah, absolutely. I think he got humbled today quite.
Yes.
This last couple
last episode. Yeah.
Yeah, for sure. Cool. Well, Sarah, thanks so much. We really appreciate it. This is going to be a show that's going to, I mean, I think, are they already writing season 3? And they'll probably start filming it pretty soon. So we'll look forward to wrapping up the season, and then we'll look to next year. And I'm hopefully, I got to talk to Nicole. We traded some messages, but Nicole said she really wants to talk about the show. So we're hoping to get her on for the season.
I love those guys too.
Yeah, never mind the music.
Yeah. Big music fan. So
cool. Right on. You should write into them as well. Whatever. But like, if you want it at the end of the season, if you have any hot takes or you want to wrap anything up, let me know. Maybe we could record a short little segment we could tack in there, or you could send us in a voicemail, or, email is fine as well if that's your preferred, medium, whatever. But I really do want to hear what you think about the season at the end. So we'll figure out one way.
I'm interested to see how they're going to wrap this season. Like what's going to happen in the next couple of episodes, because we're at the end of the shift. So
yeah, and we know we've got 2 more to go.
Yeah.
So a couple more episodes to go. So like, what is it going to be?
Yeah.
Hopefully they don't jump the shark and
I know
do something ridiculous. And it could just be like everybody's charting for the next hour.
Yeah. Well, like Robbie was like, everybody's got to load all their stuff in. And I was like, I had sent that in that one email where I was like, this is going to suck when they come back up because everybody has to hand put everything back in the computer.
Exactly. Yeah. That's a lot of work. So, all right. Well, Sarah, thanks so much again. I really appreciate you taking some time out of your personal life. And again, thank you for writing in. And I want to hear what you think at the end of the season.
Absolutely. No, I love listening to you guys and like all your deep dives on things and hot takes. So I used to have we used to call ourselves the Nerd Herd, like a group of friends.
I love that. The Nerd Herd. I've never heard that one before. That's perfect. I love that.
We would go to the Marvel movies together and
nice.
The Lord of the Rings thing.
Oh yeah. Well, we're your people.
Yeah. And so, and then I moved away and everybody moved in other places. And so this is you guys are my new Nerd Herd.
Awesome. No, that's great. I'm so glad. Yeah, it's going to be House of the Dragon's going to be good. I've been doing my rewatch right now. And I know Anthony and Steve are going to be, covering it as well. And yeah, it should be good. Well, anyway, I'm glad that you're with your herd. So. Awesome.
Yeah. Thank you so much.
Okay. We'll talk again soon.
All right. Bye.
The Lorehounds podcast is produced and published by the Lorehounds. You can send questions and feedback and voicemails at thelorehounds.com/contact. Get early and ad-free access to all Lorehounds podcasts at patreon.com/thelorehounds. Any opinions stated are ours personally and do not reflect the opinion of or belong to any employers or other entities. Thanks for listening.